testhim 1.
Testhim 2.
Testhim 3.
She's got it.
Yeah. It's always the little question intonation, isn't it, that people have? Am I doing this right?
I love the pause of, should I say testhim 3?
Yeah.
Absolutely.
Yeah.
Welcome to the testhim podcast, everyone, where we're here talking all things fertility as part of our testhim community.
Is that your mobile phone out your pocket?
Sorry about that.
That's all right.
As long as it's not broken.
Yeah. And we welcome Lalana Songra. I got that right, yeah?
Yes,
Wonderful. And you are, see, I've already forgotten, medical advisor
correct.
at Examen Lab.
I am indeed.
Brilliant. Thank you for joining us. So today, and it's a real shame again that we haven't got Mike here because he would have loved all the technicalities here. So, you've got the dumber part of the parts
Yeah,
of the,
you got the two idiots.
yeah, of testhim. But we're going to talk sperm DNA fragmentation.
Yeah.
Maybe amongst other things, which we've covered many times before. And it's almost a recurrent theme. But I think it's going to be really interesting to explore, obviously, what you do at Examen, the type of tests you do. Specifically, I think we might explore double-strand DNA fragmentation testing. So that's kind of a new thing that's kind of emerging, isn't it, in the market? And just kind of help people understand. I think what's really important also today is that we help people understand that there are these different tests. There is the Examen Comet test. There is the SCSA style assay that we offer through our lab.
Yeah.
And the fact that we're working in partnership, which is a really wonderful thing.
That's exciting.
Yeah.
And that people kind of understand what's behind these tests and why one test may be chosen by a clinician over another. I think it's really important, isn't it? But it is about clinician's choice, really, isn't it, based on that history and their preference and what have you. But how did you get into this world? What's your kind of background?
Well, I came from a very medical family, so I wanted to do medicine from quite a young age. And so I was lucky that I was able to study it at university, and I went along and I loved it, and I decided quite early on I wanted to do surgery. So I started surgical training with a focus on urology and general surgery. And I did love it. It's obviously tough. And the work-life balance was hard. But I think that what I always found more interesting in it was trying to figure out why certain things were happening, like the real root cause of stuff, and especially wondering why people were getting recurrent infections, for example, or why certain people were getting complications after surgery. And obviously the NHS is an incredible job, but the hospitals just don't have the resources or the time to kind of delve into people's lives a bit more. So I decided that maybe surgery wasn't exactly for me, and I left after 4 years and I did a public health master's, and I wanted to focus on health promotion because I loved that side of things where people didn't always have to rely on us for help. It's what could we do to help people help themselves. And I find that the kind of health promotion but behavior change was something that was really interesting. And you realize that as doctors we're always taught tell people about what they can do and educate them, but you realize that knowledge is just a very small part of it. And actually you have to give people the opportunity and the motivation to change as well. And so I thought that was just I thought we could do so much good for people if we could focus on that side of things as well and kind of empower them to help themselves. And then so male fertility was kind of a great intersection of the two of those, urology with the male health, the health promotion, and obviously fertility as a major public health issue at the minute, and helping people to kind of understand how they could optimize their fertility health and not necessarily always have to rely on a medical profession or fertility experts, but give them a little bit more control over their journey and see what they can do to help themselves. And then it's easier for others to help them as well. So that's kind of how I got into it.
That's awesome.
Honestly, the people we get in here, it's like I said, we're just the dumb ones. Just asking questions.
Yeah, it's incredible. Yeah, to go from surgery, and I mean that's years and years of study. There's some life commitment right there.
It was so fun. I wouldn't change it at all. But I am really glad with what I'm doing now. And I think it's so interesting, and I love learning.
Yeah.
So it's so interesting that like even doing urology, we don't really get like that much exposure to male fertility. That's something that maybe comes a little bit later on.
Yeah.
And even then it's maybe not something that is as,
Well,
common.
it's a very, very much a subspeciality, isn't it?
Exactly.
If you want to do it, you have to go and study it and
You have
find
to
it,
go
but it's
and-
not in the urology kind of education pathway, is it?
syllabus or anything. So it was even like amazing to learn. There was so much that I hadn't kind of come across before. So I loved that element of it. And then obviously there's, the policy side of things, and there's, working with like amazing people who are campaigning and like raising education and, awareness. And so, yeah, it's just been really kind of enlightening, and yeah, loved it.
And it was you said a master's, was that right?
A master's.
In health
And it was
education.
Master's in public health, but with a focus on health promotion.
And did you then sort of narrow that down to fertility specifically, or was it
No,
much
that
broader than
came afterwards. I was actually, this is completely irrelevant to fertility, but I was actually interested in gambling harms initially.
I thought you were just saying gambling. I thought you were just going to I'm just interested in gambling.
Yeah.
Oh, okay, right.
No, that was what my focus was, but it was, and I think it's just everything is, you realize in like public health, it all comes down to the framing of an issue. And so like I was focusing on gambling, and it was how industry frames gambling as like a leisure activity. But it's just so relevant to basically every field of health, where you realize that the framing of an issue. So say if you take fertility and like how maybe previously it was framed as a female issue, and now that narrative is shifting to realize that, we have to take a much more couple-centric approach. So shifting the framing seems to be often like the very first step in bringing about change and helping people to kind of understand. So it did like teach me a lot, but yet nothing fertility in my health promotion course at all.
That's really unique, isn't it?
Yeah.
It's really unique. Yeah. To go from gambling to fertility, but
I
that's
know,
really unique.
just but there's a lot of parallels just with how you help to bring about change. So yeah, it was just, and obviously Examen's a Belfast, company, being from Belfast, so everything just worked out really nicely.
Yeah. And then that kind of, so interestingly then, with that kind of experience and that with your masters and what you've done in public health and education, kind of, how does that kind of make your view of the male fertility space kind of, how does it seem to you, and what you're seeing in the industry, and what needs to happen, and what we could be doing better and all of that?
Yeah, I think one of the major things I saw initially was like the framing that we spoke about. And like the first shift was trying to help people understand that it's not maybe a female issue first and foremost, but that it's like together, that couple approach. And even finding it really interesting is that, when you're speaking with people, you can often find there's a bit of a narrative like, the issue was with me, or the issue was with me. And, people maybe take a lot of, like guilt, and like carry a lot of burden that, someone's maybe pinpointed an issue just with one person. But maybe like the more I've learnt about it, you can see that actually it's very much like there can be contributing issues from like both sides, and that, maybe a man with a sperm with a different egg would have had a different outcome, and similarly that egg with a different sperm could have had a different outcome. And so it's actually quite an approach that would benefit like looking at both, the egg and sperm contributing factors together, rather than focusing on one, not finding an issue, and then focusing on the other. And not saying that if you find an issue in one part of, say, an egg or a sperm, that then you say, okay, this is what we're going to work on now, and then not investigate any further to see, is there simultaneously like occurring, issue that you can maybe address and optimize both together. But just from the public health of like, I think fertility, is more and more becoming, known as like and recognized as a public health issue. But I think that's maybe only been in the past year or so. But you know what it's like whenever you're suddenly in a field that you haven't been in before, you start to think that now suddenly everyone's talking about, fertility, or everyone's talking
really
about it as a public health issue. And you're like, is that my bubble? Or are people actually speaking about
we're
it?
very much in a sperm bubble.
I think so.
You go out there and chat to anyone in the reception area and say, I work in sperm. They'll be like, what?
Yeah, they're just not on. Yeah, because it's strange how you think that suddenly, like, maybe your algorithm changes or something, and now all you see is, male fertility or something like that. So I think just saying, the public health implications, say, of like miscarriage and mental health, like to take one, for example, or the fact that, we should be looking now not just to optimize fertility health, but maybe what we can do to be optimizing the health of the next generation. And, I think that's really interesting. and just the the population, or like the fertility decline in terms of populations, like Western populations. And of course there's many reasons why people are maybe choosing not to have children, but where people do want to have children, like what we can do to help them get there. So I think, from a public health perspective, it's such a huge topic, but one that's maybe not spoken about as much.
Oh, absolutely not. I'm quite interested then in terms of your studies, like where you've then maybe looked at, I don't know, if you look at obesity or gambling or alcoholism or drug abuse or any major public health issue, is there a common theme that in terms of awareness, education, finance, research that actually goes across them all, and that also includes fertility, do you think?
Interesting. I think there's like, whenever you speak about maybe behavior change, you speak about like certain models. And I think there's always been a feeling that if you just give people the knowledge for, say, if you give them knowledge on how obesity can affect, their health status, or how alcohol can, impact or lead to liver disease or things like that, people think that that's maybe enough, but there's so much more to that. And it's like, why that knowledge is out there, but why isn't that then bringing about change? And it's so like in all of those fields, there's something that is preventing people from making those changes, and whether it's opportunity, whether it's motivation, or just whether they have the kind of resources or even the energy to expend on that particular, topic at that time. Like they may have a lot of other stresses going on in their life that they just can't think about making like nutritious meals, for example. And that is really prevalent, I think, across a lot of public health issues, that we're just not maybe giving people the resources and the tools that they need. But one thing I think is so interesting in public health is that kind of idea of social capital, and like empowering, say, communities to work together to bring about change, and having particular agents of change maybe within that community who's like a leader in that field, or has a voice that people listen to and respect, and that they can bring about a lot of change. And then you get the early adopters, then you get the late adopters. But it's amazing to see how people can bring their fellow like neighbors and like community along the journey with them. And I think rather than being top down and maybe governments or policies trying to bring about change, like starting it from the ground up and helping people to kind of corral themselves, because they know what the issues are and they know what the barriers are. And so if they can address them. And so I think that's the same with fertility. It's like, there's a whole community out there that are supporting one another, and they know what the issues are because they've been through it themselves, and they've seen, what worked for them, what didn't work for them. Yeah. And so I think that community aspect is really interesting and something that we can like promote a lot more in public health.
Really interesting.
Yeah, because I think as well, like life in general these days is like everyone's on fast forward, right?
Yeah.
Almost to the point where you can't really take up a breath of fresh air to think about something other than, right, I need dinner, get to bed, go work tomorrow, eat, sleep, repeat.
Exactly.
You get to Sunday and you go, oh my God, it's Monday tomorrow morning. And actually like come back to that kind of community thing, when we've supported patients through our fertility group, they are taking a step out of their norm to be part of a community that has got, people in there that have had their own issues, and they can support one another. And the benefits of that are quite incredible, aren't they? We've seen some really, really nice case studies there. But that community is so important.
Yeah.
It's a shame that we have to force ourselves out of the norm to join a community like that, when actually it should just be integral to society. And I think as a population, away from fertility, I think we'd be much healthier if we actually had a bit more of a chilled out lifestyle.
Yeah.
My wife and I went through, we traveled through Italy some years ago when we were going through our fertility treatment. And we did it just as a 2-week, like we didn't book a hotel. We just kind of literally got a car in Milan. Yeah. And we had to get to the south of Italy at some point 10 days later. And it was so nice to we stayed on farms, we stayed with nonnas, we ate with locals, and actually those 10 days, we often talk about it, how we were part of different communities. Yeah. And yes, of course, it's a holiday, it's a little bit different to go to work, but by doing so, it's like really nice to like just chat to new people and experience new things, etc. But I think what you've just mentioned there, I think has a huge benefit for just mental health, and then you can pick up tips about how to eat healthier or live healthier.
Completely. With someone who's like living in your situation and seeing like, is also doing a busy job, or, is also like has the stress of, whatever going on, but this is how they made it work. And so it's just that thing of helping people to like the easy. It has to be the easiest choice, and so it's like, how can we make this like healthy choice the easiest choice
way
for people?
Yeah.
And yeah, it's often just seeing it, you know, in real life. Okay, this is how this person did it. This is how I'm gonna do it now. But that sounds amazing.
It was great. I was awesome.
Yeah,
I
a great
loved it.
reset.
I love road trips anyway. But yeah, it was a great reset for us during that time. And of course, we ate like amazing Italian food. It's like one of my favorite foods. But yeah, I just think communities is really key, and the patients that we've supported, I've benefited from you know, the fertility community itself. It creates knowledge is power.
That's the thing, there's so much knowledge that exists like in these communities. It's just like, how do you get it out there? And that's what I think it is so special, and that's what I find really interesting about the public health course, because I was so kind of medical and like maybe scientific, and, you know, learning about, you know, things like randomized control trials and things like that. And I had to learn all about social research, and really it was about getting, you know, starting from an issue, and then you worked from the bottom up rather than like a top down approach, and building knowledge as you went, and then finding out, okay, this is interesting, let me explore this, rather than coming with like an idea and thinking, okay, how do I prove this idea? You see what's actually out there in the real world. And I was like, it opened my eyes like hugely. I thought it was incredible.
Yeah, because there is that kind of there's almost like this wall between medicine and science and patients, really, isn't there? And it is, how do we take all this excellent stuff that's going on in the science world and how do we get it to the patient in a meaningful and valuable way?
Yeah.
That's a really hard one, I think, to cross over. And I was going to say, like, you know, the number of people that will have been to a consultant or a GP and the GP said, like, you know, say high blood pressure. Okay, you've got to cut down on your saturated fats and and you've got to eat this type of diet. Off you go. Yeah. How many people actually then achieve that?
I know, and it's hard, but I also can say, like, you know, I've been in the position of, say, when I did my GP placement, you know, everyone knows you have 10 minutes, and how many things can you counsel someone on, and there's such a gap to then say, okay, this is what the advice is, now this is how you can achieve it, or like, you know, a separate, you know, person you can go to who's going to help you on this. But I think you're right. The research is so important, because like everything has to have, you know, a really good evidence base, and there's, you know, all different types of research. But you can see now, even when I was in medicine, people are so much like more well read and like well versed in the, you know, they're often like, we call them expert patients, because they are living it, and they are, you know, this is what kind of, not their whole life is about, of course, but is something that is very important to them, and they take the time to research and see all the new things that are coming out. Whereas as clinicians, like maybe we study in medical school, and unless there's a particular topic that you're interested in, you keep up to date with everything that's coming out, you can kind of fall behind quite easily on the
especially
research.
for GPs.
There's so much to keep up on. So patients actually educate you a lot when they come, because they've had the time and the kind of have put in the energy to update themselves, and then they'll say, I read this, and then you go away and read it, and you say, okay.
I used to learn masses. That's how I kind of, my acupuncture practice being a fertility-based practice. I learned a lot from, you know, some of my training and working with Zeta West and other bits and bobs. But it's when that patient came in and said, I've got X, Y, and Z. Yeah. I'm like, okay.
Yeah. Let me quickly look it up.
Well, no, you just said to him, tell me about that. Tell me what that means. And like, okay. And then, go and do some further research afterwards. Yeah. You know, it's, was it walk in my shoes for a day or whatever that saying is, isn't it? You know, and then
exactly.
And then you really learn. But it's also about that, like, people need support, don't they? You can't just go and change your diet. You know, you can't just, like, some people just can't do that, or they don't know how to do that. And this idea of community, and you do see it in the fertility space, and there's a few different apps and platforms that have popped up. And I think something I heard when we had Jazz Kelsey actually on the support group recently, and he said, you're going to get change in the industry from patients. Patients are going to drive it. Yes. And so actually this community and the support group's actually a classic example of this, isn't it? It's like guys speaking to other guys and saying, you know what, I went and had this done, I went and had that done. We've got one guy in the group who's just discovered he's got a near-on 4mm varicocele, but his IVF clinic have said nothing about it.
Oh wow, and just find out through the kind of speaking with other people, and then
go in to then see a different clinician.
Wow.
And it was exactly the same for you, wasn't it, Toby?
Exactly the same. Yeah, I mean, myself and others that have been part of the support group, having been led that IVF is the kind of way to go, this is what you need, have found out about DNA fragmentation, which obviously we'll get onto in a sec, but varicocele being an issue. and then having treatment for that and having consequence of natural and still needed maybe IVF to some degree.
With better
But
chances,
exactly,
hopefully.
yeah. And then they've gone on to have a next round of success, and we've got little ones about now because of that very thing, haven't we? It's really powerful, isn't it, when you think about that community and what that's allowed someone to understand. I mean, there's one guy who's openly sharing his story now, whose fork in the road similar to mine was: do I do another round of IVF or do I treat my varicocele? He chose to go down the route of the embolization, and that fork in the road completely changed that person's and my person's life forever, regardless of what the science and data says around what's recommended, with the NICE guidelines obviously changing it at this present time. They're real life stories, right? That is exactly what I've lived through. That's what that person's lived through.
But this is an interesting
powerful
point, actually, and this will be interesting to get your view, Lalana, because you've then got patient stories. I did this, I did that, and this can be dangerous because I took all of these supplements. I did this, I did that. We've talked before on another podcast about personalized medicine, and actually, what's right for one person isn't right for another person.
Yeah,
there is, I guess, that danger in communities of people saying, "Oh, well, I did this, I did that," and patients then thinking, "Oh, I'll go off and do that." So, how do you balance that kind of community education against the science, and also these anecdotal stories, anecdotal evidence, which scientists don't like because it's not a randomized control trial.
Yeah.
Well, and then I'm going to throw in, how do you do a randomized control trial in the fertility world?
In the fertility world.
So
really hard.
There you go. Over to you.
Okay.
All of that.
Let me think, I think, and as you were speaking, those kind of, questions were coming up to me as well, because I agree. I think it's so important that we recognize that all of these different areas of like education and knowledge have like importance and are very relevant to kind of foster, but that not any single one of them is good enough on their own. So we need to empower patients. We need to, ensure that they have access to, accurate information. But we also need to bring the research to the clinicians so that if they're ever, asked a question, say, for example, by the patients, or if they want to discuss it with patients, that they feel empowered to have those conversations in like quite a, quick but like easily understandable way. And so it's kind of like a two-pronged approach to make sure that everyone is, on the same page. But I agree, the anecdotal side of things, I always say it's that thing of for example, would want to know, like, not is it working for everyone, but is it working for me? And so whenever people are saying, that we'll just go ahead with this because in 80% of cases it'll work. And I say, I'd love to know, I'd love to try before, is it working for me, for example, before I then proceed with this, for example. And I think that, say, things like varicocele repair or surgical sperm retrieval, obviously they are invasive and they carry, surgical risks and things like that. And so I'd be a lot more cautious about maybe that side of things. And that's where the evidence base is so important, where you have large numbers of people and you can see the complication rates, you can see the benefits. And so you want to make sure that what you're counseling people on, you really feel that there is a benefit rather than a risk. But for things, sometimes I think there's a bit of reticence to say, we need to see, what exercise and, healthy eating and nutrition and lowering stress, really does for people's fertility. And I'm like, but those are things that we counsel people on
just
all
anyway.
the time. Because even if there's not a particular benefit for fertility, because that's really hard to prove, and that's where the randomized control trials come in. It's like, these are non-invasive, very positive health behaviors that we would be encouraging people to undertake anyway, and that will help them in a whole like host of other things in their life, not just fertility. So like, I wouldn't have any qualms about recommending, a particularly like nutritious diet or an exercise regimen of 150 minutes a week, because that's going to benefit them. And I can't see that there's a negative with that, even if there's a small chance that it will maybe improve their fertility health through relieving stress or, making them feel that there's an element of control in the process. And then again, that helps reset and think, okay, I'm doing something positive, and then a mindset changes. But that's so hard to prove in research. And randomized control trials in fertility, of course, are difficult. So we just obviously, at Examen, we do a lot of research, and we just want to put out the kind of highest quality evidence that you can. And then it's about numbers and working with, lots of fertility centres and just seeing a widespread kind of approach and seeing what comes through in the research, and is that supported by multiple groups, and then you have a strong evidence base that way.
Yeah. It's a real tricky one, isn't it? Of balancing this out and it's something we butt up against all the time, and I'm sure you do.
Yeah.
When you go and speak to literally had a meeting with the urologist last week, and he's like, yeah, I'm still a bit on the fence about sperm DNA fragmentation. This is a urologist with male fertility expertise, and a very good one. But it's like, okay, I want to see more data.
Yeah.
Like, okay, well, how much data do we need?
How much data do we need? And that's the thing. And sometimes, whenever you're looking at the other things that we have been integrated into practice for so long, that don't necessarily maybe have the strength of evidence base that now people are requesting for sperm DNA fragmentation, for example. But it's just what people feel comfortable with. And so the more they use it and the more they see kind of the benefits of it in their own practice, like that in itself is data that people... there's anecdotal, but then there's clinicians who maybe see 100 patients a year, and even if they're not collecting the data, they're starting to see trends and they're starting to see the benefits of it. And so that's another interesting way. But there's a reticence to performing a non-invasive diagnostic test that I'm always kind of interested about as to what really is the concern here. And I think it's just about, I see the benefit of it from, it's always like, okay, well, what are we going to do with that information? How is it going to change management? Yep. I'm like, well, the first step is we want to know. I imagine if I was a fertility clinician, I would want to know if there's maybe two people sitting in front of me in a clinic. I would want to know, is there maybe an issue in either of the people sitting in front of me that I could do something about to optimize their chances of a healthy pregnancy? And so I think from a male perspective, we see that sperm DNA fragmentation is a very powerful tool at identifying, predicting male fertility, even more so than semen analysis. Yep. But we do semen analysis so routinely, even though, there's increasing evidence to show that it alone is not enough to accurately predict male fertility. And sperm DNA fragmentation is exactly the same process for the man. It's just in the lab. Yep. It's done differently.
All just off one
but
sample.
I'm like, first of all, you want to know, is there an issue in the male sitting in front of you that is contributing to this problem? Because then that will impact on your treatment decision. But I think more importantly, it'll impact on your risk counselling for that couple and help them to understand why perhaps they've been having difficulties conceiving, for example. And if there's anything that man in particular can do to optimize his fertility health, and then you can counsel what you can do from your perspective as a clinician or fertility expert to help him as well. So I think it's just important to have those discussions rather than thinking, how is this going to change my, IVF versus ICSI, for example.
Yeah, and I can talk from a patient perspective there, from my own kind of journey, is that once... all the time we had that kind of, I hate the saying, but unexplained infertility. And that's kind of where we were at until I had my DNA frag test done. That just feels like you're just searching in the dark with your eyes shut. What do we do next? Where do we go? Please help us. We just want to have a baby, a healthy baby, and we want to start a family, and we're now 6 years deep. What do we do? But I always drum the drum of knowledge is power.
Yeah.
But when you've then got something that highlights a possible issue, and the more pieces of information you can get of what that issue might be, it creates clarity in respect that if nothing can be done and you have to close the book, that's the end of your journey. This is how we found contentment with it, was that if there was nothing more we could have done, we knew what the reason was, and we shut the book that was the end of our fertility journey. We both wouldn't know that'd be very difficult to end that journey, but we both were kind of satisfied that we've done all we can do, and we've got a specific, okay, here's a very likely chance of the reason why we were unable to have a family. Thankfully, there was obviously an intervention that allowed us to improve our chances, and obviously we did all the diet and lifestyle things on top of that as well. So we can't say one specific thing changed, but that for a patient, regardless of what the data says and the science says, honestly is the most empowering thing ever. And once we had that information, I did a little YouTube video of when I had my embolization. It was a really emotional, literally switched the camera on and was talking quite openly about, this is it now. We kind of run out of money. We've kind of done all we could do. We had the embolization done. We were hopeful then the DNA frag would improve. But I came home from that day really vividly. It was in the back end of the pandemic. So Katie wasn't in the hospital with me. I got picked up by her in London, and then we drove home, and that journey home was like constantly talking about, well, this is it now. We've done everything. We know what the reasons are. We've done everything we can do. And honestly, with hand on heart, we had so much contentment at that point.
Yeah.
That whatever the outcome it was here, we knew we've done and uncovered every stone unturned. And that's thanks to you, mate, to be fair, because...
No, not just me. There's a lot of people.
There's a few people,
involved.
but you were a big catalyst in it. Obviously, I saw Jonathan Ramsey as well, which kind of like was the ice on the cake. But the first time me and I met... was me giving him a pot of my semen.
Yeah.
That was the first time we met in person. So we became brothers very, very quickly, just to destigmatize that. We weren't in the same room when I produced it, mind. But you know, it created such a big catalyst on like us having contentment for the way we move forward. And I've digressed a little bit away from what we're talking about now, but the importance and the power of that is massive.
I think that is so true, because I think that's underrated, maybe in, say, from a fertility clinic perspective, for example, where it's like, yes, people want to have a baby, but also there's a huge part of it that's wanting to understand, like, why are we having these issues? And also feeling like, as you say, you've done whatever you could in your power to investigate and improve things. Because I remember, like, say sometimes even, you know, maybe you've experienced this yourself, when you go to the hospital, for example, and you have like a really bad tummy ache or you've got really bad pain, sometimes like just letting people know what it is, and maybe there's nothing I can do about it, but even just knowing what it is like such a relief to people sometimes, because maybe they're thinking there's a million other things that it could be, and there was something in particular in their head. They were like, I'm worried about this. But if you give them a reason, it helps people to kind of come to terms with something, whereas the unknown is just can really send you into a spiral. And that thing of, you know, as a clinician as well, it's so unsatisfying to have a conversation like, I don't know what's going on here, but let's try this. It feels like maybe you're just throwing
Fobbing
something
them
at a
off.
wall and hoping it sticks, versus if you have a conversation like, from the, you know, test that we've done, this is what we've identified as the issues, and based on this, this is what we would recommend. That's a much more satisfying conversation for people to have. And especially, you know, say, for example, with IVF or ICSI, where maybe, you know, 2 and 3 conversations that clinicians are having that day could be negative ones, you know, having that understanding that you've also done what you can to optimize that person's chances, and also appropriately like help them to understand what their personal chances are and prepare them for, you know, maybe your chances aren't, you know, 35%, but maybe they're 50 because things are looking great, or maybe they're 10%. But that is important for people to know. Say they have, you know, a pot of money that they like one final pot of money that they're deciding what to do with it, knowing, you know, maybe a complete understanding of your fertility health will help you to decide, okay,
Where's the best place?
like where's the best place to put my money, or to, you know, do I want to put my body through this? Because we often speak about, you know, how expensive fertility treatment is, but it's also like so physically and emotionally demanding, and it's not just about the money. It's like, can we go through this again for maybe a 10% chance, but I would be for a 35% chance willing to go through with it, for example. So I think, we could definitely do a lot more to help people to have a fuller picture when they're going into these fertility clinics. And I'm always interested by how much focus we put on the female side of things in the diagnostics and optimization whenever, you know, we're born with our eggs. And you can obviously try and keep yourselves healthy and optimize egg health that way, but sperm are produced every, you know, 3 months or a full cycle, but actually they're produced every day, you know, and there's such a golden window of opportunity there to help men to understand what they can do to optimize their health. And we often leave it, you know, to a year down the line of maybe trying, rather than at 6 months. Maybe why don't we have a conversation about, okay,
or we're thinking of having a family, let's get ready now.
Exactly.
And 3-4 months.
We like, I would know what if I was trying to conceive what I need to do, but I'm not sure that many of my male friends you know, would know.
So
for
true.
example, Emily,
So true.
we're doctors, you know, but we don't even get that information out there. So I think that we're missing a real window here to help people to optimize themselves before they even, as you say, go down that journey.
Yeah, it's absolutely massive. And something you said back there is like, people do like to have a label. You know, much as we end up sometimes getting put in boxes or whatever, but actually having a label of a diagnosis makes a massive difference. It was a huge thing for me with my Meniere's disease. When I finally got diagnosed, I was like, oh, right, that's what it is. And I remember my business coach at the time said, well, what difference does that make? I was like, well, it makes a huge difference because I know what I'm dealing with now. you know, and men are being deprived of that opportunity of having a label. Maybe labels aren't always a good thing, definitely, but having something to put their hat on and say, oh, okay, I've got this, that and the other, or I understand that this is the issue.
Yeah.
And therefore I can go away and look at it and deal with it. And we're just not doing that for men.
Exactly. And it's just that acknowledgement, you know, of like what you're going through is maybe something that is, you know, real. Because especially whenever there's something that you're going through that it's hidden to like the outside world, or you're sitting in front of, you know, what is a seemingly healthy, you know, set of individuals, and then suddenly there's a major, you know, event in their lives that happens, and they're trying to have a child and they can't, and that is so...
Oh, it's confusing.
Yeah, confusing because like I feel perfectly healthy, you know, we're living, you know, in a lot of circumstances that's how it kind of unfolds. And so it's that acknowledgement that actually, you know, it's not, you know, that there is something here that we can try and work with. But if we don't know, then you're just left in the dark. And it's,
if we don't look, you'll never know.
Exactly.
Yeah. Right. This has gone off on a tangent.
I love it.
Sorry.
No, it's been brilliant. It's really interesting. I had no idea we were going to go in this direction, but we did promise, or I promised at the beginning, we would talk a bit more about sperm DNA fragmentation.
Yes.
So, how long have you been with Examen?
Coming up to 8 months.
Oh, okay. Wow. But you've been involved on the
I've been
fringes
involved
for
on the
quite a while.
fringes probably from January 25.
Oh,
Yeah, so
okay.
just over a year.
I thought it was a lot longer than that.
Yeah, no, it's I just started like officially in May time.
Oh, wow. Okay. Oh, wow. We're definitely going to grill you now then. So, in terms of then obviously your study and your background, kind of, how have you got your head around sperm DNA fragmentation and the research and the science of all of that?
I love reading the research papers.
I was sort of wondering where that was going to go then as
I
well.
was just like, I really enjoy the research side of things. And it's interesting, like in like medical school, you can kind of decide to do like a separate degree in the middle of it. And my degree was genetics. So I also had the kind of genetics background that I was interested in as well. So it really, you know, whenever I'm reading about DNA fragmentation, and even, you know, there's like interesting papers that come out that as men get older, as the sperm cells are constantly replicating themselves or you know, creating new sperm cells, there's more mutations that can arise and how that can then lead to certain things. And so it's just all very fascinating to me. So the back like catalogue of research on sperm DNA fragmentation was so extensive for me to get through that it felt like insurmountable for the first couple of months. But I definitely am getting there where now I think I have a good enough grasp of the research and the kind of body of evidence that's out there to feel like comfortable in having the conversations. But there was a lot to read through.
Yeah. And there is a massive amount on the Examen website, isn't there? I remember when I used to run the Examen test through my practice as an acupuncturist. That's how you ended up with a pot of Toby's sperm you know, coming down to me. But I remember going onto the website. I was like, gee whiz, there's so much research.
Yeah.
So.
And I think it's rare in medicine to find, you know, because sometimes when you're starting out, and you know, not that I'm ever thinking about getting a Nobel Prize or anything like that, but when you're reading and you're just like, how do people make such huge breakthroughs? Because it seems like there's so much knowledge out there already now that, you know, what people are doing is like tiny increments on something that's already established. And then I came to like male fertility and say maybe like the sperm side of things. And I was like, there's a whole host of information that we don't know. Like, and it's rare to find a field in medicine that's like so under kind of examined. And looking then, so as you say on say the website, you know, there's a lot of stuff on lifestyle factors, but every single type of lifestyle factor and how that impacts on semen quality, and then semen quality and how that impacts on fertility and miscarriage and live birth. And there's just so many ways you can look into it. But obviously I have maybe a bit more of an interest in the public health side of things as well. And so the lifestyle factors and the smoking, and I just think it's so interesting, even with say vaping that comes out now. Like I'd love to know, you know, and I think that sperm is so perfectly set up for research, because you could maybe say have someone who vapes a lot, for example, and then if they're happy to stop, say for 3 months, like you could see they act as their own kind of control. So there's so much like work that you can do with sperm DNA fragmentation research.
So having gone into all the papers and got your head around it all, how would you summarize what you've read?
I would summarize it that to me it seems, and as you say, sometimes you can be in a bubble and you know you're reading certain things, but to me it just seems like sperm DNA fragmentation is the best tool that we currently have to discriminate, say, between a man who is having fertility issues and, say, a fertile man, compared to if we look at semen analysis. So if I was a man who was in a partnership that was struggling to conceive, I would love to know what my semen quality is looking like, and is that contributing to. So I think as a tool to predict male factor infertility, it's so powerful. And I think what's even more powerful coming through the research now is that, and this is maybe where double-stranded sperm DNA fragmentation comes into it, is that I think, say, in situations like pregnancy loss, where, you know, a couple has been able to get pregnant, and so maybe the assumption was that, well, they're getting pregnant, so there's sperm there, and it's able to fertilize an egg. So it can't possibly be an issue with the male side of things. And so now that we're seeing increasingly how semen quality can have effects on like later embryo development, but implantation, recurrent pregnancy loss, and live birth, I think that is so interesting, and that will help with that frame shift we're talking about, where we see that, you know, there is a really good 50-50 contribution here from the male and female side of things, not just for conception, but for the whole process.
Yeah. I've just suddenly remembered a conversation I had with an embryologist. So you're saying all of this. I remember sitting with this embryologist having breakfast in Gatwick Airport on the way to Eshrei. It's my first ever Eshrei, actually, and we're chatting about sperm DNA fragmentation. And he's sitting there eating his eggs and bacon, and he's like, yeah, it's got nothing to do with it. It's all about the egg. And I was like, what? How can you actually think that?
How can it be?
Yeah.
If it's 50% of the genetic material?
Yeah.
Like how, and even the fact that, you know, that sperm don't have their own DNA repair mechanisms. And so the fact that the egg repairs, you know, the DNA in the sperm to a certain degree, but obviously as eggs get older, and we're seeing increasingly the age at which people are having children is older, then that becomes even more important, that semen quality is as good as it can be. So the egg has to do, you know, less work, for want of a better word. But it is mind-boggling to think how people can really just hone in on the egg and completely ignore the contribution from the sperm DNA.
Yeah, it just doesn't make sense.
It doesn't make sense. Like biologically.
Yeah, put all the science to one side.
Yeah.
And let's just say, right, you've got some DNA here, some DNA here. You're going to mix it together to make a whole new set of DNA. Surely you need both elements to be like. It's just common sense.
It's just common sense.
Yeah.
I know.
But there we go. But yeah, these are the challenges we all face, right? So yeah, let's talk about double-strand break testing in a little bit more detail. Then, do you want to kind of summarize sperm DNA fragmentation and what's going on there and why it occurs?
Yes. So obviously you said you've spoken about sperm DNA fragmentation a lot, but just in case maybe this is the first time people are hearing about it, sperm DNA fragmentation is a type of sperm DNA damage, as you know, and it refers to breaks within the DNA molecule in the sperm, and that like backbone of the DNA molecule. And so as you can imagine, because it's like a ladder, there can either be a break in one of the strands or there can be a break in both of the strands. So that's where there's a break in one side of the strand, that's where we call single-stranded sperm DNA fragmentation. And then both breaks, breaks in both sides of the strands would be double-stranded DNA fragmentation.
And just to be clear on this, because we talk about it being like a ladder. Obviously, it's a twisted helix, isn't it? So when we talk about those strands being broken, because for a long time, actually, when you see the images of DNA, you've got the two main strands and you've got the bits that connect them across. They're the bases, or the base pairs. Yeah. I always thought it was those bits that we're talking about being broken, but actually we're not. We're talking about...
It's actually more about the backbone,
so those two
and there can be then, you know, missing bases. And so that's why if you imagine that, as you say, base pairs, for example, like one base, there is a base pair that will always connect. So say there's, you know, a particular base that will always connect with another base. And so you can see how then single-stranded damage, where maybe only one base or one side of the ladder is missing, it's much easier to repair because there's a template for repair there.
Yeah, because it's like for like either side.
Like
the same one.
Exactly.
Oh yeah, we've got one over here. We'll just copy it and put it over here.
So we will find the pair. We know what the pair is for this one, so we can just replace it. Whereas when there's a double-stranded break, and almost like you could have both sides of the equation missing, then you don't really know. Okay. So that, in my head, that's why double-stranded breaks are more difficult to repair. And so where even lower levels of double-strand damage can have more serious consequences than even higher levels of single-stranded damage because of that repair mechanism.
Also, I guess it depends on which elements are missing as well, which of those base pairs are missing. If it's a break at a certain point, that's absolutely critical for embryo development.
Yeah, say in a particular gene, for example. And so, obviously, a large body of research that's been done on sperm DNA fragmentation always focused on total sperm DNA fragmentation, and that involves both single-stranded and double-stranded damage, and looking at the two together to create that kind of total level of damage. And so there are certain types of tests, as you say, the COMET test, when you're doing it in neutral conditions, that you can just isolate the double-stranded damage. And so that then allows you, say, in research studies, for example, to see what is double-stranded damage alone doing for, this particular, say, embryo development or pregnancy loss. And so what has been coming out of the research over the last decade or so was that single-stranded or total-stranded damage together is high levels of that can really impact on a couple's ability to conceive naturally. So where you're struggling to conceive, then if you have high levels of total SDF, then that can be a contributing factor. Whereas whenever couples have, or a man has a high levels of double-stranded sperm DNA fragmentation, what they were seeing in the kind of research was that there was delayed embryo development in the later stages, but that impaired implantation rates, but also very strong associations with male factor recurrent pregnancy loss, even stronger than if we were looking at total sperm DNA fragmentation alone. And we've got a paper that's coming out soon that also looked at a strong association of double-stranded sperm DNA fragmentation with IVF, live birth outcomes. So there's a kind of feeling that double-stranded sperm DNA fragmentation is more relevant at later stages of the pregnancy, whereas the kind of total and single-stranded damage is impairing that actual ability to conceive a pregnancy in the first place. But as you say, perhaps the egg is more able to repair single-stranded damage. And then you think, okay, like where are these two types of damage originating from? And the research would support that single-stranded damage, which kind of largely makes up the total SDF because it's more prevalent, is with like once the kind of sperm has been produced and as it's moving through the reproductive tract, it's exposed to a variety of stressors. So that could be, as you say, heat stress from a varicocele, but also inflammation just from, high BMI, undiagnosed infections, for example. So these are all, reversible risk factors.
Which usually drive oxidative stress, don't they?
Exactly, and oxidative stress. Whereas double-stranded sperm DNA fragmentation, the research seems to support there'll of course be an element of oxidative stress that can, create double-stranded damage as well. But they think that during that process of sperm being produced, that there's defects in certain parts of the process that can make the sperm more likely to experience double-strand sperm DNA fragmentation damage. And so it's perhaps more testicular in origin and less so as the sperm is traveling through. And so that means it's potentially, maybe less amenable to repair, say, through, simple lifestyle changes. We still have to see what, varicocele repair does for double-stranded damage, because it's maybe a little bit, the research is maybe newer than total sperm DNA fragmentation. There's a lot to learn about double-strand DNA fragmentation and how we can mitigate against it as well.
Wow.
It's fascinating, isn't it?
It's absolutely fascinating. And what I'm sort of listening to here is like, because this is relatively new, really, isn't it? Double strand, kind of the research.
Maybe around, 10 years or so.
Yeah. Which is, but the fact that we're talking about this level of detail with sperm DNA fragmentation.
Yeah.
But you've still got people out there that are saying, I don't believe in it.
I know.
They don't believe in it at all.
Yeah.
Let alone the fact, okay, we can now start to differentiate.
Yes.
If this guy's got this,
different parts
he's going to
of the
struggle
process.
to conceive, but if he's got this, you're going to get recurrent pregnancy loss.
Yeah, because the way I kind of see this, because I'm a complete idiot and try and think really layman, but the way I kind of see it is like, if you've got like a sperm under the microscope, an embryologist would always try to choose the one that looks more morphologically correct.
Yeah.
If they could, at that point, zoom in a little bit more to see what that DNA is like, they would also choose the one that would be slightly better DNA. If then they could zoom in a little bit more detail and look at maybe double-strand DNA, they would also try to remove those ones, right? So that's how I see this whole process. Is like you've got, for a guy, you've got like the semen analysis. I had a pretty normal semen analysis. My morphology was a little bit lower than it should have been. But as I've zoomed in through each of the tests that I've had done, I've then obviously found out what damage I had present, and I had quite a high level of damage. But that's how I kind of see this. I kind of like it's like almost peering through the microscope and zooming in right to the point.
And as you got
Exactly.
more and more detail, it determined your path.
You've got
and your treatment.
You've got
options.
more clarity, haven't you? Because you've got that information. But it's it's quite amazing from just like someone like myself who is the idiot, as I always say, is that there's these little sperms that are swimming. Most people don't even realize that they can have two tails or two heads or like be misformed, etc. Let alone actually the most important thing in that sperm, regardless of what it looks like, is that little bit of information inside it, the DNA. And same with the egg, right? The egg's got that little bit of DNA. The two blend together and life gets created. So for me, it's like, why would you not want to know what that looks like? Because we often talk about conception as a success of IVF, but success to me is having a live, healthy baby.
Yeah.
That is the most important part. I almost don't care about conception. There's no point conceiving if I can't have a live birth at the end.
Yeah.
Because the trauma that a miscarriage has, and my wife would go through, etc. Like, by understanding what those ingredients look like at the start, again, it comes back to that kind of clarity message. Is that prepares you of what the outcomes could well be.
Yeah.
But it honestly blows my mind. It's like we are talking on such a small level.
Yeah.
And that we're able to see this level of detail genuinely blows my mind.
And I agree with you, because that is like such a good analogy, because you can also imagine if you were in, say, a fertility clinic, or someone was trying to explain your sperm health to you, and they said, like, we can look at it kind of, from an external perspective and just say, how do they move? How do they look? But we can look deeper into the sperm quality, and we can look even deeper and say, okay, do you have DNA damage? But what type of DNA damage do you have? I think there's very few people who would just stop at okay, I'm just interested in like what it looks like on the outside, because most people would understand that, it's the genetic, like once, that how the sperm moves is only so important up to the point where it fertilizes an egg. And then after that, how it moves, it doesn't matter. What matters is the DNA quality, like what information is now going to be passed on to your child. And it's so interesting. And even that thing about, trying to help counsel about risks, like we, when we were doing the study that looked at double-stranded sperm DNA fragmentation and live birth outcomes in IVF, we're working with multiple fertility centres across Europe. And so they looked at like 300 couples who were undergoing IVF. And we looked at the double-stranded sperm DNA fragmentation and how that impacted. And as I'm sure you know, when we're talking about IVF and counselling people, we often speak about the female age, and that's really the determining factor for IVF live birth outcome. And so in this age group, these are your chances, but that doesn't take into account the male factor at all. And so this with the data from this study, you were able to have like a matrix where you had female age along one side and double-strand sperm DNA fragmentation along the top, and then kind of work out the odds of success. So at this female age, with this level of double-stranded sperm DNA fragmentation, your odds of success of a live birth are this. And so you can see how at a lower female age and higher double-stranded sperm DNA fragmentation, so you can really see that how they come together, and it's not one or the other, but it's that whole whole picture, which is so interesting to now we have an idea of how is the male side of things contributing to this, and just helping with that understanding of, okay, I thought my chances were 30%, but actually we have really good levels of sperm DNA fragmentation, so actually we're a little bit higher, for example.
Yeah, because in some ways you could say actually then that the IVF clinics are potentially misleading couples on the live birth outcomes. Because if they haven't got that data,
they don't have all the information.
Yeah, they're not intentionally doing it.
Yes.
Yeah, that's a very good point. But
it blows my mind though, all this. It really does. And I always try and bring it back to what I do day to day. So I race cars.
Not day to day, you don't.
Day to day. I drive trains, but racing cars is my thing. But obviously I like when people ask me about my race car, they obviously see it. It looks pretty, great looking race car. But the things they ask is about how much brake horsepower, how fast it go, the things that are kind of the internals of the car. You've got the ECU, which controls all of the amazing technology in there. But then you've also got me as the driver inside that controls that machine. And the way I kind of see egg and sperm is kind of like those two forms together, is that you need both a good driver and a good car to make it perform well.
Yeah.
Whichever way around you call the egg and the sperm in that scenario, but it's that's kind of how I see it.
Yeah, exactly. Like it's a full machine, like all together, and the two parts kind of become inseparable. At a point. But I think that's a really good analogy, because otherwise it's hard to kind of imagine that these two are coming together. But I also think it's so interesting whenever it's like, say, for example, the sperm, when you say maybe people aren't so comfortable with sperm DNA fragmentation as clinicians. And then I've seen research where men are saying in fertility clinics, if they get given a normal semen analysis, even if they have known risk factors for infertility, say, for example, really high levels of stress or elevated BMI, if once they get a normal semen analysis, they have the green light to just be like, nothing to do with me. I don't need to engage. Even though clinicians will say to me, I give them lifestyle advice anyway. And this comes back to that behavior change and opportunity and motivation. If you give someone the knowledge, but they have no motivation to do this because you're saying you're fine, actually, they're not going to engage. Whereas, say, for example, we know that maybe 20 to 25% of people who are struggling with infertility can have a normal semen analysis but elevated sperm DNA fragmentation. And when we looked at male factor recurrent pregnancy loss, we looked at 100 couples, and 66, there was no female factor identified in these couples. So 66 of the men out of 100 had a normal semen analysis. But when we looked at total SDF, it was elevated in over 60% of those men. And double-stranded was elevated in over 50% of them. Hell. So it's like a huge proportion of men that we're maybe giving, false reassurance to. And then they have no reason to engage with the, health, instructions or, advice that clinicians say, oh, but I'm giving that anyway. So, what's it really going to change? It's
but
like,
but
the
in
mindset.
Those percentages then, which are shocking, that's a lot, isn't it? That's a huge amount.
Like much more than we thought.
Yeah. How many have then got a varicocele? How many are carrying an infection that they carry, passing to their partner? Low-lying infections, whatever it is. But because their semen analysis is okay, and because we're referring them into an IVF clinic, all of those items,
there is
all of
no
those
further
things,
investigation.
But they're doing such a disservice to the women in this space because, and I can talk from my own experience here, is that I was told that. I was told my semen analysis is fine, don't worry, we'll just do ICSI. Like, you're off, you ain't got to worry. Just turn up on collection day, give me a sample. That's all you got to do. Yeah, that was my attitude at that point. I was like, I'm good then. Okay, I just need to look after my wife. Yeah, she had 5 and a bit years of guilt and shame of I was the problem. Sorry, Toby. She even said to me several times, "Why don't you go and find another woman that can give you a baby?" Like heartbreaking things to hear, and I absolutely adore her, because of that was the conversation. Yeah. 5 and a bit years down the line, I had a huge level of DNA frag.
It's so sad.
And the disservice has been, and suddenly the polls turned very quickly. Then I felt so much guilt that, oh my God, all this time I was the problem. I could have done something sooner, but obviously I just wasn't empowered at the time. And that's why this is such an important message, because with that information armed us with then the correct way forward. But poor Katie, bless her, she went through 5 years of hell when she didn't need to,
And this is the thing, like, I think sometimes people think it's, about, okay, now we want to shift the blame, from women. Okay, now we're going to focus on men, and actually it's all men's fault, and it's not
about
that
being together.
And as you say, it's like whenever you're in like say, if you are going through a fertility journey together as a couple, for example, like you're a loving couple who just wants to support one another. Exactly. You're not looking to, put blame here and there. So often I hear that kind of, there was a podcast, I think it was like 3 JA players, and they were saying, their partners were all going through, they were all going through recurrent pregnancy loss, but a large part of it had been focusing on their female partners because they had all received normal semen analysis. And they were saying, I almost wish that there was something that I was told that I could explain, what was doing it that on me, so that I could support and, share a part of that with my wife, whereas you feel very, that you out of control and you can't help anything, but you just want to support that person and you see them struggling. So I agree. I don't think it's not about, putting the burden on anyone in particular. It's just about knowing, like, together. And it's so much easier to do things like lifestyle advice and, exercise together, like getting up in the morning, being in it together. Yeah,
not drinking alcohol, all that
exactly.
Kind of stuff.
But that's what happened when we first met you. So we had that kind of conversation with you about kind of what we both doing.
About the Ben and Jerry's.
About the Ben and Jerry's ice cream. I was a bit partial to some Ben and Jerry's. That was our emotional blanket. Obviously not a very healthy advice, and there are other ice creams out there. But I think the turning point for when we met you and actually understanding more about male factor infertility, you shed some light on that. But you gave us purpose to it as a kind of couple. Katie at that point felt very much that actually we can do something together, and it's not just all me here. And I actually felt like, okay, maybe there is some influence from me at this part. And then obviously the test investigations obviously soon explained that. But having that kind of how can I put it? Like the consultations we had prior to that was very much like gynecology led. It was all kind of looking at Katie. That then it kind of spearheads the direction of travel. The minute you start talking as a couple, from the professional side, I mean, because obviously you are in it together, it kind of makes you feel like you're doing it together again. And creating a baby is that, right?
Yeah, takes two.
It takes two, doesn't it?
Yeah.
So
But it's that motivation piece that you mentioned, the public health thing, isn't it? It's like there's not enough to help motivate the men, I don't think, at the moment. Because like you said, normal semen analysis, off you go, or IVF, ICSI will fix this.
We'll fix it,
ICSI can overcome a lot of the male factor issues. It's definitely got its place.
Yeah.
I think one of the powerful messages we've heard from one of our podcast guests or on the support group or wherever is, what a man is doing in terms of his sperm health. And you mentioned it, genetic capability, competence. That is about, it's not about getting pregnant.
Yeah.
That is about the future health of your child.
Completely. And that is never talked about. I really feel like infertility kind of clinics, even per se, that it's not about just it's not about getting pregnant, as you say, because people are like, I don't really care about that. I want a healthy child. And it's such a big part of the conversation that I don't think is spoken about enough.
No, and it's maybe it's just a bit too far and a bit too abstract for people that are right in the trenches of trying to conceive. Like, we just want to get pregnant. The thought of, okay, well, what impact am I having on my child that is still yet to even be conceived is that's quite an abstract.
It feels
concept,
a long way away, doesn't it? Yeah, when you're already in the thick of it. But the thing that bugs me with the industry, it might be controversial to say, is that under the HFEA, success is measured on a positive pregnancy test 2 weeks after the embryo transfer.
It's one of the measures,
one of the measures, and that, but that's publicised as one of the success rates, and like that's not, for me, that's not success.
No, God no,
that's not success. That's like saying, what is it like saying? It's almost like winning the World Cup final, but actually we're gonna have penalties and you're going to lose those penalties. Like you haven't actually got
what you were hoping to achieve.
You haven't actually got the full outcome.
And the live birth success rate is much lower than the success rates that clinics advertise as success based on HFA guidelines. And that used to really bug me when we used to read the leaderboards, and when we was choosing our clinic, that was like I drummed into that data and was like, hold on a minute, how is that?
I think they've changed that. I think they have changed how they do that.
But it was at the time when we was going through that, I was like, oh my God, how is that successful? Success as a baby, right?
Yeah, absolutely. Coming back to the tests, just so we'll kind of wrap up fairly soon, but I think a lot of patients know a lot about sperm DNA fragmentation because, like you say, that kind of community and the awareness that goes on out there. There is still a lot of debate about it, and definitely in the scientific and in the clinic world. So there will be patients that will be listening to this and their consultant said, don't bother, we're just doing ICSI anyway. I think it'd be quite interesting to know for patients. I think one, that there are these different tests available, SCSA, Comet, and within the Comet there's the total and double-strand breaks. How... when a guy goes to see a urologist and actually gets these tests, what's the decision kind of tree or pathway for a consultant? Say, I want you to have this test or I want you to have that test. What is that decision tree and why is that so important and why might it differ? There's a lot of questions there.
So I think that largely it depends on what that person is presenting with. If they are presenting as struggling to conceive naturally, then the first port of call would often be the total sperm DNA fragmentation, because that's what has been linked in the research most strongly with an inability to conceive naturally where levels are high. And then, as you say, there's the different tests available to do that. There's the Comet, the SCSA, Halo Tunnel. There's a variety that people can choose from. And that often then comes down to what that particular clinician and clinic offers, and they have their own kind of, preferences for different types of tests. And then it's whenever, say, people are presenting with either recurrent pregnancy loss, for example, or recurrent ART failure, that's when then maybe you have to think a little bit deeper and think, okay, do I want to try and establish perhaps what type of DNA damage is present here? You know, we've identified often these investigations will be alongside the female. So they'll be looking at the female, and hopefully they'll also be looking at the male there. And that's where double-stranded sperm DNA fragmentation can perhaps tell clinicians a little bit more in depth as to, okay, this double-stranded sperm DNA fragmentation is very specific profile associated with male factor recurrent pregnancy loss. So if it's normal, we can say, okay, there's probably not a male factor contributing here. But if it's elevated, then we can say, okay, this is strongly associated with male factor recurrent pregnancy loss, and now this is what we can do about it. Because, for example, if you never look at that and you have recurrent pregnancy loss and you go down an IVF route, for example, you're not incorporating a male factor issue at all. Similarly with recurrent ART failure, often a lot of people will have a total sperm DNA fragmentation level at the beginning, maybe of a workup, or they've read about it and so they've asked to have it. And they can go through ART and maybe they're still not having success, and perhaps their total SDF has been normal or could have been slightly elevated, but it doesn't mean that their double-stranded sperm DNA fragmentation levels are normal. So that's where then people will maybe choose to delve a little bit deeper into the type of DNA damage and say, okay, is there a double-stranded DNA damage issue here that we haven't detected with the total sperm DNA fragmentation test? And then they look further and say, okay, is there a special, say, technique that we should use for this next ART procedure, for example, to address high levels of double-stranded sperm DNA frag?
Yeah. So it's quite complex, isn't it? And I think what's important is it's that clinician oversight, and it's that comprehensive history and understanding what that total picture is.
Yeah.
I think it's probably a little bit, using a phrase by Alan Pacey, buyer beware of the idea of going out, because you can just go get a DNA fragmentation test at some places, but you may not necessarily get the right clinical oversight, and you may be paying for a test that isn't as accurate as it could be, or it's not as validated. And I think that's one of the important things to say, is that there are all these different tests. Some are more validated and more reliable and repeatable than others.
Yeah.
I think that's really
have a maybe greater evidence base behind them. But as you say, you wouldn't necessarily want to, people are, say, if you're not able to get this in the NHS, which I don't think you're able to get sperm DNA fragmentation in the NHS, which, is a whole other story. But from if you're going down a private route, your money is so precious, and you want to make sure that what you're spending your money on is a valuable spend of money. And so often cost comes up with, sperm DNA fragmentation, for example, and clinicians saying, oh, well, it's expensive, so why don't I just bypass and go straight to ICSI, for example, and, and it's like, well, that actually understanding what the kind of various components you're working with is very valuable spend of money, because hopefully, well, maybe people want, if they have a healthy pregnancy and a healthy live birth and they have one child, perhaps they may go on to want another, for example. And so it's that whole process of, like, it's good at the beginning to understand what you're working with. But secondly, ICSI is just injecting a sperm into an egg. If you're injecting a sperm with per DNA quality into an egg, then the egg has to do, some work to repair that DNA, but it may not be able to repair it all. So why are we not optimizing the sperm quality as much as possible? And then perhaps they may still need ICSI, but at least we've done everything we can to choose the best. You're working with the best of the best.
You've moved the dial up a bit, haven't you?
Rather than maybe like the best of your worst, because you have a couple of months to try and optimize your sperm quality as much as possible. And I think people would like to take that opportunity if they could, especially because, reading like the average spend can be up to £10,000. When you're thinking that sperm DNA fragmentations are maybe a couple of hundred, pounds, then to me, sometimes I know where I would like to focus my efforts initially. But of course it's the clinicians and it's the patients, like, having those discussions together. And that's why both sides need to be as informed as possible, so that they can come to like a very kind of shared, informed like decision.
Yeah, I think that's a really good point, isn't it? Because like when you go to IVF, and if you need IVF, and it's certainly a great treatment to give you the outcome. But when it comes to money, both you've got a currency of chips there as to purchase that service, but you've also got an emotional bunch of chips as well that you've got to be really careful how you play them too. And actually, just by holding those chips back briefly to decide what is the next best steps before you kind of go all in. So when we had our decision to make whether we was to go through another ICSI round or to have the embryonisation, because that's kind of all the budget we had at the time, we placed those chips at that time to the embryonisation because of DNA frag, on the basis of we understood what benefit that would have. We knew that it wouldn't give us a complete miracle cure, but realistically that was the better place to place our chips. But let's say, for example, that you retest in 6 months' time, having done diet, lifestyle, maybe that's the factor that's causing it, for example, and then you come back and go, right, the DNA fragmentation's looking much more improved. You're more than happy then to go all in with them chips and go, right, here you go, let's go, because I've done what I can here.
Yeah.
Emotionally, I'm ready now. I've got my financial chips ready to play. I can go all in on that. And that might be your only one hit on IVF.
But you've given yourself
a shot.
And I wish it wouldn't take so long sometimes to get to that point of, say, where you're looking and you're speaking with people and it's like 3 cycles in of failed cycles. And then it's like, okay, now maybe let's investigate the male factor a little bit more in depth. And it's like, well, now potentially the egg is even 2 years older or 3 years older, and now even if you optimize the sperm quality as much as possible, if you had optimized it 2 years ago, your chances would have been even better. So why are we waiting to so many years down the line and so many, as you say, emotionally and physically demanding cycles, almost running cycles as diagnostic cycles to say, okay, what is the biological data that comes out of them, and but we have opportunities for diagnosis before that are non-invasive, and even females, we sometimes do invasive diagnostic tests as well, but there's a lot less maybe concern sometimes about doing those types of tests rather than looking at the semen, because again I think the thing is always just like, well, let's do ICSI, but increasingly we obviously work largely, in the UK and Ireland and Europe, but the conversations I largely have are with people in the UK, and it seems like sometimes there's maybe a bit of a shift towards ICSI that I wasn't expecting rather than IVF. And I was speaking with, people in other countries, and they were saying largely across the world, like, we're moving away from ICSI and wanting to focus more on IVF where possible because of the disruption to the egg membrane, for example, or the fact that, we're not addressing the male factor issue just by doing ICSI. And so it's interesting that if we just see ICSI as like the cure for everything, then, in a couple of years' time, we might find ourselves in a tricky situation where we can actually do a lot more non-invasively to improve things and optimize as much as possible. And then if we need to, go down an ART route. Yeah.
So let's bring this all the way back now to your public health work. Put that hat back on with the sperm DNA fragmentation hat. How would you like to see things change in the public health arena around this?
That's a really good question. I would love it. Now, maybe if there's any like fertility clinics listening, they probably won't love this answer. But I would love it if we could get to a point where we address as much as possible all the reversible causes of infertility before people even get to a fertility clinic. Yep. So I would love that there was either GPs are under so much pressure at the minute. So whether there was, some type of family planning service that could be set up in the primary care situation where if a couple said they wanted to conceive or they were, in the initial phases, I don't say 3 months in, rather than waiting a year, they get counselled then at 3 months and say, okay, let's have a look at your various lifestyle, at your diet, at your, say, stress levels, or, investigate for infections or varicocele, things that we can do to optimize your fertility health right now. And then couples have, without that time pressure that sometimes you feel once you've been trying for a year, you're in an IVF clinic, for example, you feel a time pressure that I can't possibly, wait 3 months to optimize anything anymore. We just need to crack on. If we got people earlier and examine the male side of things particularly, then we can address all the reversible causes and hopefully limit the number of people who even need fertility help in a clinic. That would be my ideal.
Brilliant. Get Love to that. It. Sort it out. It's everything that we talk about as well. Yeah. But That's been such an awesome conversation.
Oh, I love that.
Thank
Great.
you so
Really
much.
enjoyed it.
Thank you for coming.
I've really enjoyed it. Thank you.
Yeah, we could go another hour and a half, I'm sure.
Yeah, definitely. I've really had a good time. Obviously, I was nervous before, but it was really fun to speak with you both.
Oh,
the testhim podcast.
Yeah, it's very
Everyone has a good
relaxing.
time. But awesome. Thank you so much. Thanks for all the great work that you do at Examen and on the public health side of things as well. And
Thank you
I
so
know you're
much.
working closely with Fertility Action as well,
Yeah.
which is really, really great.
Yeah.
So yeah, thank you. And yeah, let's test him out.
Yeah, keep being awesome. Thank you
Thank
so
you
much.
so much. Thank you, guys.
Cheers. Ta-da, everyone.